In today's lecture, we will discuss the mouth, tongue, and the mechanism of swallowing. My name is Carlos Andres Suarez-Quian. I am the author of this work and will narrate the material to you. We started the discussion by listing the components of the mouth. They include the oral vestibule, the oral cavity proper, the teeth, the gingiva or gums, the tongue, and the palate. And with respect to the functions of the mouth, they're listed here. They include grasping of food, chewing of food, preparing food for digestion, and phonation or speech. All these functions may seem straightforward to you, but no doubt, if you've ever had a toothache, they can present with problems. The area between the teeth and the cheeks, lips, and gums is called the oral vestibule. One of the functions of our lips is that of grasping. If grasping is indeed a function of the lips, let's examine them in more detail. They are shown here. Although, I bet that if I were to ask many of you to point to where the lips begin and end, you would point to the wrong spot. Given that one function of the lips is grasping, the lips must have some volume, and they do. They begin at the nasolabial groove. And think why it has to be so. Lips would not be very practical if they were just narrow slits. But what is the area that most people call the lips? It is actually the skin of the transitional zone. The skin is so thin here and so rich in blood supply that its coloration is due to the underlying vascular supply deep to this area. The boundary between the pale skin and the skin of the transitional zone is known as the vermilion border. It turns out that the upper lip also has a characteristic feature, two ridges with a depression in between. It is given the name of philtrum. Turns out that the absence of a philtrum, even whether it's symmetrical or not, is immediately identified by observers as aberrant in appearance. And perhaps it is the reason that this area of the upper lip was given the name philtrum. It literally means love charm in ancient Greek. In fact, the human face is difficult to recognize in the absence of a philtrum. As an example, I show you this painting of mother and child. The philtrum is clearly evident in the mother. We recognize this as a human face. But what caught my attention when I first saw this image was that the artist recognized the importance of including the philtrum in the face of the child as well, even though the child's face is not meant to attract the gaze of the viewer to it. And here's another example. It is a small figurine of a saint. The figure is about 12 inches tall, but in such a small statue, the artist felt compelled to add a human feature to the face, the philtrum. I brought up this discussion of the philtrum because the absence of a philtrum is a well-recognized outcome of fetal alcohol syndrome in babies born to alcoholic mothers. On the left, I show a chart of the potential for loss of the philtrum as a function of fetal alcohol syndrome. If you were to see someone missing a philtrum, the face would appear aberrant to you. The worst case scenario of missing a philtrum, however, is that of cleft lip. Cleft lip with or without cleft palate occurs in about 9 to 18% of infants with fetal alcohol syndrome, but is not diagnostic of the syndrome. However, women who binge drink during the first week of pregnancy are more likely to have a baby with a cleft lip or cleft palate than other women. Binge drinking is when you drink 4 or more drinks in 2 to 3 hours. In general, cleft lip is likely the result of a combination of genetic and consumption by the mother. I should mention that one of the most incredible and charitable organizations that deals with cleft lip is Operation Smile. They perform hundreds of medical missions per year throughout the world. I should mention also that there's another clinically significant fact that you should be familiar with, this time with respect to the skin of the transitional zone. Although it is possible to develop squamous cell carcinoma on any part of the face, The thinness of the skin of the transitional zone makes it more prone to develop squamous cell carcinoma, especially the bottom lip, because it receives more sunlight than the top lip. As to the lymphatic drainage from these lesions, remember, we mentioned that ultimately everything ends up in the deep lymph nodes of the neck. But if there's any silver lining with cancer of the lips, is that the metastasis from the center of the lips is initially to the submental lymph nodes, and these drain to superficial nodes first. Hence, it is possible to envision a scenario where these cancers may be more easily treated than those of the periphery. And here's the lymphatic drainage scheme. We described that lymphatic drainage from the face and scalp drains to a pericervical collar of superficial lymph nodes, but ultimately it will eventually drain to the deep lymph nodes. Hence, bottom line, any cancer of the skin can be deadly if left untreated. Moving inside the lips to the area of the vestibule, we know that there is a ridge of mucous membrane that attaches the upper and lower lips to the respective gums. These are the frenulum. You can feel these with your tongue. Their function is to anchor the lips to the jaw and keeps them properly aligned so that we keep food inside our mouths when we eat. Another important structure of the vestibule is the opening of the parotid duct, which opens near the second upper molar after piercing the buccinator muscle. At one time, to image parotid tumors, the duct was cannulated and radiopaque dye sent retrograde into the parotid gland in a procedure known as a sialogram. CT imaging is now used, and this painful procedure is avoided. Moving now to the oral cavity proper, we define this region as that area that is bound by the teeth, gums, palate, and the floor of the mouth. It is continuous posteriorly with the fossal isthmus, the archway of the palatoglossal and palatopharyngeal arches, and the function of the oral cavity are also listed. We chew our food and prepare for digestion. We also speak. Let's start the discussion by naming the two principal bones of the oral cavity, the maxilla and the mandible. And when we look at the skull and the sagittal plane, we see that the maxilla helps form the roof of the oral cavity with its palatine process of the maxilla. The second bone that contributes to the roof, horizontal plate of the palatine bone. Together, these two processes form the hard palate. Looking now at the hard palate from below, we can see foramina. Anteriorly, there's the incisive canal for the exit of the nasopalatine nerve and sphenopalatine artery. And posteriorly, we have the palatine foramina, the greater and lesser, for the corresponding nerves. As with the lip, the hard palate can also fail to fuse, and this is known as cleft palate. The condition is more rare than cleft lip, but is also more insidious, and children can fail to thrive. In severe cases, shown on the image on the right, the cleft allows for a direct communication between the oral cavity and the nasal cavity. The incidence of choking is exacerbated in these cases. Looking now at the mandible, we see that on the inside there is a groove, and this groove is called the mylohyoid groove. It is from this line that the mylohyoid muscle takes its origin to then extend to the hyoid bone to help form the floor of the mouth. Looking at the teeth for a second, let's describe them briefly. We see that per half of the upper and lower jaws, we have 2 incisors, 1 canine, 2 premolars, and 3 molars. Note that in this individual, the last molar has been removed. As to the type of joint that forms between the teeth and the mandible and maxilla, it is called gymphosis, perhaps my favorite word ever that I once played in Scrabble. Gymphosis refers to a type of joint in which a conical process is inserted into a socket-like portion, which grants mobility to the teeth. The mobility helps teeth from cracking while biting down hard on a solid object. If you like to eat ice, thank the confosid type of joint that we have for our teeth. So what is the function of teeth? I list them here. The obvious one, of course, is to cut, grind, and otherwise chew food, but they also support the lips and cheeks, providing for a fuller, more aesthetically pleasing appearance. They help to maintain an individual's vertical dimension of occlusion. Without proper alignment, the temporomandibular joint can be impacted. And finally, along with the tongue and lips, the teeth allow for the proper pronunciation of various sounds. As you probably know, one can lose her teeth and become a dentulate. A dentulism is a condition which can have multiple causes. In exceedingly rare cases, toothlessness may result from the teeth not developing in the first place, a condition known as anodontia. However, in most cases, it is a result of permanent tooth extraction in adulthood. This may or may not be due to dental caries, periodontal disease, gum disease, trauma, or other pathology of the face and mouth, for example, cysts and tumors. In those under 45 years of age, dental caries is considered to be the main cause of toothlessness, whereas periodontal disease is a primary cause of tooth loss in older age groups. Which brings me to the dentist's office. As you can imagine, these visits can be painful because of the two nerves that we discussed earlier that are branches of the trigeminal nerve. The superior alveolar nerves, a branch of maxillary division, and the inferior alveolar nerve, a branch of the mandibular nerve. The question then becomes how to anesthetize these nerves. Let's do the inferior alveolar first. Recall when we studied the infratemporal fossa that the inferior alveolar nerve enters the mandible at the mandibular foramen after traversing the fossa. The foramen, we now see, is guarded by a bony outpocketing called the lingula. Dentists insert the needle into this approximate area, catch the lingula with the tip of the needle, then infiltrate the area with anesthetic, which will anesthetize a complete lower jaw on one side, including the outside of the mandible, where the continuation of the inferior alveolar nerve exits as the mental nerve. So this is straightforward if you require work on a lower molar, but what about an upper molar? Is it as simple? And you know by the way I'm asking that the answer is no. First, you have to decide whether to anesthetize the front teeth or the back teeth. If the front teeth, then you deliver the anesthetic to the area of the incisive canal. This will anesthetize the oral cavity side of the front incisors and the canines. If you wish to anesthetize the premolars and molars, then you have to introduce anesthesia into the area of the greater palatine foramen. And now you have the whole set of upper teeth anesthetized on the oral side of the mouth. But wait, what about the vestibular side of the teeth? Well, if you want to play it safe, some dentists select each individual tooth and anesthetize it independently to ensure that it is anesthetized. This does beg the question, why not simply use the same approach as we do for the lower jaw? And the answer can be seen in this drawing. There's no feasible way to get at the maxillary division of the trigeminal nerve after it passes through the foramen rotundum to become the infraorbital nerve before it breaks up into the individual nerves that serve the maxilla. The approach would be too delicate and risky to attempt. We now move to describe the blood supply to the oral cavity, and for this we think of the external carotid arteries. From the external carotid, two branches will emerge, the facial and the lingual, that will deliver blood supply to the oral cavity. The facial will go mostly to the vestibule, whereas the lingual will enter the oral cavity from the floor and enter the tongue. The remaining blood supply to the oral cavity is from the maxillary artery, one of the terminal branches of the external carotid artery. And we see here the maxillary artery will send numerous branches into the oral cavity to ultimately terminate as the descending palatine and the sphenopalatine arteries. These arteries then accompany their eponymous nerves. We have seen these drawings before when we discussed the paths of the sphenopalatine nerve and the greater and lesser palatine nerves. The sphenopalatine artery will travel to the nasal septum and exit at the incisive canal. The greater palatine artery will descend and exit with its nerve to serve the upper hard palate. What about the veins? If you know the arteries, you know the veins. This concludes the description of the oral cavity. Let's now move to the tongue. We start by providing a description of the tongue. It is a mobile muscular organ that is partially in the oral cavity proper and partially in the pharynx. Its function is to assist with mastication, deglutition, articulation, and oral cleansing, and of course, osculation. The tongue can be divided into an anterior 2/3, consisting of the apex and the body, and the posterior 1/3, the root. Where the 1/3, 2/3 areas meet, there is a blind foramen, the foramen cecum, which is the remnant of the thyroglossal duct. The tongue is an incredible organ for sensory modality we use for taste. And for this, we use all those little bumps you see on your tongue, the taste buds. You'll receive much more detail describing the function of these, but at the gross level, we can describe them in terms of their appearance, and I will list the specific function of the taste buds. For example, we have the valuate papilla at the intersection between the front and posterior aspects of the tongue that resemble little valleys. The foliate papilla are on the sides of the tongue. They resemble folios, individual sheets of parchment. The mushroom-looking papillae are called fungiform, and the long, slender papilla are called the filiform papilla. In general, the papilla increase the area of contact between surface of the tongue and the content of the oral cavity, and all except the filiform papilla have taste buds on the surface. Finally, on the posterior third of the tongue, we have large bumps also, but these are the lingual tonsils. Given that the tongue is a mobile, muscular organ, presumably it is strongly anchored in order to carry out this function, and it is. However, let me tell you an anecdote that would scare the heck out of me when I was very young. I remember hearing as a child, when an older relative or family friend died, I would ask what was the cause, and the reply was simply, they swallowed their tongue. I'm sure this was set to try and diminish the anxiety in a young mind, to try and provide some explanation of the great mystery of life, but to me it caused no end of worries, and put the fear in me that perhaps I too would swallow my own tongue. So what are the anchors of the tongue? The root of the tongue is joined to the epiglottis by median and two lateral glossoepiglottic folds. The body of the tongue is attached to the mandible, hyoid bone, styloid process, and palate by muscles. Finally, the inferior surface of the tongue is attached to the floor of the mouth by the frenulum of the tongue. Bottom line, that tongue is not going to be swallowed. But what could have given rise to those urban legends that we swallow our tongues? Because I have also heard similar tales from individuals from other countries. What can happen is that the airway can be obstructed by the tongue, as shown on the top panel, following paralysis, and the patient suffocates. In fact, the tongue relaxes during general anesthesia, requiring intubation. And if you have ever taken CPR, you know that simply by tilting of the head will partially open the airway. Of course, the benchmark way to help a patient in this situation is to intubate them. Let's now mention the scourge of relationships, snoring. If you live with someone long enough, believe me, there will be snoring. As we mentioned during the nasal cavity lecture, a deviated septum may impede normal airflow during the night and lead to snoring. But the soft palate too can be the cause of snoring. If the soft palate is low and thick, it can narrow the airway and lead to snoring. If the uvula is longer than usual, it will also impede the airway. People are born this way, so snoring can be considered normal, but being overweight often exacerbates the snoring. Surgery is sometimes performed to remove the uvula, and this may help. But now we move to sleep apnea, and the tongue certainly plays a role in sleep apnea, as indicated in the slide. Note the path of air that should occur in normal breathing during sleep. In obstructive sleep apnea, however, the tongue can be relaxed enough that it blocks the airway, or in heavyset individuals, the airway can be impeded. In men, a neck larger than 17 inches in diameter, even if you're fit, is associated with what is called obstructive sleep apnea. In women, the neck size associated with OSA is 16 inches. You may have heard that now you can insert an oral device and it will eliminate all forms of sleep apnea and even snoring. While these devices may help with alleviating some forms of snoring and sleep apnea, if the cause for the condition is due to an exceedingly long uvula, the devices are unlikely to be of use. As mentioned previously, the underside of the tongue is also where the frenulum of the tongue is located, which helps to anchor the tongue to the floor of the mouth, and the sublingual salivary glands are located there as well. It is also where the submandibular duct empties, just lateral to the frenulum. Of significant clinical relevance, I should mention the rich plexus of veins present on the underside of the tongue. This plexus is exploited for the rapid delivery of medications to patients, especially nitroglycerin, for the quick relief of pain due to angina. We now move to describe the muscles of the tongue, and first we will describe the extrinsic muscles of the tongue, the ones that move the tongue. The principal one is the genioglossus, the large fan-shaped muscle that makes up most of the body of the tongue. Its action is to protrude the tongue directly forward. Two other muscles that move the tongue, now shown on the slide, are the hyoglossus and the styloglossus. The hyoglossus depresses the tongue, whereas the styloglossus elevates and retracts the tongue. The last extrinsic muscle is the palatoglossus, which is just deep to the palatoglossal arch, the interior arch of the tonsillar bed. I started here to highlight that this is the only muscle of the tongue not innervated by the hypoglossal nerve. The muscle is innervated by cranial nerve 10 and its contribution to the pharyngeal plexus. If we have extrinsic muscles, we must also have intrinsic muscles, and these are all within the tongue itself. These are the ones that alter the shape of the tongue. For example, if you can curl your tongue, which, by the way, not everyone can. It is genetically pre-programmed. If we talked about muscles, we must next talk about their innervation. And for the tongue, we need to discuss both motor and sensory innervation, given the function of the tongue as both a muscle and an incredible sense organ. First, we discuss the motor nerves, which are straightforward. Except for the palatoglossal muscle, which is innervated by the vagus nerve, all other muscles are served by the hypoglossal nerve, cranial nerve 12. Let me repeat. If the name of the muscle ends in glossus, it is by 12. No ifs or buts, except for the palatoglossus muscle. We now look at the sensory components, and note that the lingual does general sensory to the anterior 2/3 of the tongue, but that cranial nerve 7, by way of the chorda tympani, does special sensory, or taste. The posterior 1/3 of the tongue is served for both somatic sensory and special sensory by the glossopharyngeal nerve, cranial nerve 9. Finally, the vagus does general sensory and taste innervation to a small patch of the posterior tongue and epiglottis. Given this innervation pattern helps us understand the gag reflex. It is possible to touch the anterior part of the tongue and feel no discomfort. However, touching the posterior part leads to gagging. Cranial nerves 9 and 10 are responsible for the muscular contractions associated with gagging. Knowing the action of the muscles of the tongue and their innervation allows you now to understand the logic of how we test for them. In normal protrusion, top panel, the combined action of the two genioglossus muscles allows you to stick your tongue straight out. If one hypoglossal nerve is damaged, however, the healthy innervated genioglossus will push the tongue to the damaged side, as shown in the bottom panel. It should be clear that this is a staged demonstration. The intrinsic muscles of the tongue appear intact, unlike the panel on the right, where the tongue is deviating to the right side of the mouth and the intrinsic muscles on that side appear damaged. Indeed, damage to cranial nerve 12 is rare, and images such as these are rare in the literature. One last clinical note about the tongue. Mouth and tongue cancers are largely a lifestyle disease, meaning that the majority of cases are related to tobacco and alcohol use. Approximately 90% of people with mouth cancer are tobacco users. Smokers are 6 times more likely than non-smokers to develop mouth cancer, and the tongue is the most common location for these types of cancers. What the lymphatic drainage of the tongue seems to indicate, the more posterior the site of the cancer, the more likely they are to metastasize to the deep cervical lymph nodes with insidious consequences. Anterior tumors do not tend to metastasize until late in disease, and, perhaps as a silver lining, these are the more frequent ones that non-smokers develop. If you're wondering who this individual was, it is Humphrey Bogart, famous actor from the 1940s. He played the lead in Casablanca. If you want to have Paris, you need to see the movie. And yes, he died from tongue cancer from smoking. I now move to the final topic of the lecture, swallowing, or deglutition as is known scientifically. I will first review the structures involved, then finish up by describing the mechanism of swallowing. First, let's review again the composition of the palate. Shown on the left panel, we have the hard palate consisting of the palatine process of the maxilla and the horizontal process of the palatine bone. On the right panel, we see the soft palate and the uvula. Together, the hard and soft palate separate the oral cavity from the nasal cavity. Recall also that when we studied the pharynx, we defined it as a tube open anteriorly with muscles, the pharyngeal constrictors, making up the posterior wall of this tube. Here again, we see the pharyngeal constrictors from behind. Slicing the pharyngeal constrictors open, we go inside the pharynx. Let's label the structures we observed previously when we studied the pharynx. On the palate, we identify the soft palate and the uvula. We can see the tongue in the oral cavity and posteriorly the epiglottis. We can also focus on the palatopharyngeal arch. And just anterior to this arch, we will look in the next slide for 2 muscles that help move the soft palate. We now look at the previous dissection after removing the mucosa. On the left is a coronal section of the naso and oropharynx. The approximate site where the section was made is shown in the small panel to the left of the section. On the right-hand panel, a drawing of the approximate area is shown. Let's put some labels on the images. We start with the obvious structures, tongue and uvula. Next, we label a muscle, the tensor veli palatini, that will tense the soft palate. And note that the tensor makes a 90-degree turn and hooks around the hamulus, the medial pterygoid plate. The second muscle we need to label is the levator veli palatini. The tensor veli palatini tenses the soft palate in order for the levator to raise it. The muscle is innervated by a branch of the mandibular nerve. The levator veli palatini elevates the soft palate, closing partially the oropharynx from the nasopharynx and nasal cavity. Innervation is by the vagus. Having identified the structures that will participate in swallowing, let's now present the mechanism of how it happens. In the first step, the tongue forces a compacted bolus of food into the oropharynx by the action of the styloglossus muscle. During step 2, the pharyngeal constrictors narrow the oropharynx. The tensor veli palatini tenses the soft palate, and the levator veli palatini elevates the soft palate, closing the oropharynx from the nasopharynx. Almost concomitantly, the salpingopharyngeus and stylopharyngeus muscles elevate the laryngopharynx, resulting in the opening of the auditory tube. That is, the reason we swallow when our ears hurt inside an airplane. We're trying to equilibrate the outside air pressure, which is higher than the air pressure on the inside of the auditory tube. An eardrum that cannot vibrate normally feels uncomfortable. Let me remind you where the salpingopharyngeal fold is. It is a tube-like structure that is the continuation of the torus sebareus, as shown in the dissection on the left. The salpingopharyngeus muscle is just deep to the fold and the muscle we use to help raise the pharynx upwards as we swallow. When the muscle contracts, the auditory tube will open up. By raising the larynx, its opening is effectively closed by the epiglottis. Not that the epiglottis moves on a hinge. That is not what is happening. The epiglottis remains almost stationary, and the opening of the larynx is brought upwards to meet it. You can put your hand on your Adam's apple, for example, and note that it moves up during swallowing, then descends. This is what's happening when we swallow. And as we swallow, the bolus of food will move towards the esophagus, and then the larynx will return to its normal position. A good study tool to review swallowing is to list all the nerves that participate in the process, and here they are. Cranial nerves 5, 7, 9, 10, and 12 all contribute in part to the process of deglutition. Stop the movie and review how these nerves participate. I now also list the motor and sensory supply of the pharynx so you have it handy and can review it. In this way, you'll be able to understand what can possibly be going wrong when a patient is having difficulties swallowing. As to testing for a functional vagus nerve, this is done every time you ask a patient to open up their mouth and say ah. As shown on the left panel, in the normal situation, the uvula should be raised straight up. However, if the vagus nerve is damaged on one side, the uvula will be elevated to the opposite side. This is because the levator veli palatini is not working on the damaged side. Remember, the levator is innervated by the vagus, and the uvula will be elevated to the side of the intact vagus. Indeed, the direction of the movement of the uvula after nerve damage is just opposite to the situation with the tongue and the hypoglossal nerve damage. The tongue moves in the direction of the damage. Okay, this has been a strange year for everyone. I know if you're succeeding, it is because you've been putting in the effort and working hard. Keep at it. It will get better, and the rewards of a successful career are immeasurable. Good luck on your future endeavors and in pursuing your dreams.